everyone to SPEEDCON 2020 and to the Speed TV of SPEEDCON. Today we have this SPEEDCON TV getting recorded in Hotel Leela Ambience Mall in Gurugram, and today we have with us Dr. Om Lakhani, who is consultant endocrinologist and diabetologist at Zydus Hospital, Ahmedabad. As you might have seen in the agenda, he is going to speak on alternative medicine and diabetes management. So let us hear from him his views on this topic. So Dr. Lakhani, what are your views on the promotion of alternative medicine for diabetes mellitus? Because every day we are looking at ads on TV and newspaper about this.
Right. So first and foremost, I'd like to welcome everybody to this beautiful day for academics. And like you rightly said, my topic tomorrow is talking on alternative medicines and diabetes, and the entire topic is actually time to burst the bubble, right? So I think we see a lot of bizarre ads for alternative therapies, not just medicines, all kinds of alternative therapies for diabetes management. There are two problems I have with that.
Right, sir.
One, the first problem I have is that, do we have any evidence for any of these, right?
Correct.
So we all move by science, and science tells us that you need evidence to prove anything, right? Now, let's say I develop my own diabetes medicine tomorrow, right?
Right.
Unfortunately, I'll be able to promote it because there are very lax laws in our country. But does it really work, right? The money which you spend for buying that, does it really work for the patient? The second problem is what is known as opportunity cost, right? Which economics, and today we are having the budget as well. So when you talk about economics, and there's something known as opportunity cost. So if I take XYZ medicine which has not been proven form of therapy, I'm not taking a form of therapy, which is a proven form of therapy. So that unfortunately the patient has a double problem. So one, you're taking something which may be potentially harmful, you don't know. On the other hand, the one which is approved, you're missing out on that, right? So that's a big problem. And I think in today's world, unfortunately, there are laws for pharmaceutical companies, there are laws for promotion of anything. But for alternative medicines, unfortunately, we don't have any laws. And that's why these, they are frequently marketed, you see ads, you see online ads on this, and that becomes a big problem in our country. So it's a big menace. I think future, there are just two ways that either the government, forces them to do clinical trials and prove what they're claiming.
Efficacy and
right, or we stop it altogether, right? That's the two things.
But doctor, this is happening, and this is happening every day. People are buying, they're spending money. So are there some flaws in human behavior that makes this marketing possible, and patients are exploited?
Yes, absolutely. So there are there is something known as a cognitive bias, right? So there's a very famous psychologist who is Nobel Prize winning. He has written a book, Think Fast and Slow. Is known as
Fast and Slow.
Yeah. So his name is Kahneman, and he's a Nobel Prize winning psychologist.
Right.
So he has done a lot of work in this sphere of cognitive bias. So human behavior, our thinking, they are influenced by a lot of biases which we have, right? And there is something we all have, which is known as we all have known as something known as blind spot bias. So we don't know our bias. We don't know what influences our decisions, right? So in general, public have of different forms of cognitive bias, and the problem is that people who market these products, they are very well aware about these flaws.
These flaws and these behavior problems.
Behavior problems. So they try to exploit. Now, when you have a problem, there are two ways. Either you can help the person get rid of the problem, or you can exploit that for your own benefit. And that's the unfortunate part.
Because he's looking for a solution.
Looking for a solution. So what happens is that, for example, patients are constantly hear the word herbal and natural and all that, right? Bought from the foothills of Himalayas, right? So patients get attracted to these terminologies because there is a bias that since their childhood they have been told that if it comes from Ganga or if it comes from Himalayas, it is pure, it is pristine, right? So harmless. These harmless, right? So these are words which come potential magical properties, right? So they have already been primed for that, right? And once they see these ads, they get attracted to that because there's a cognitive bias which they have, which attracts them to these products. And again, like I said, A, we don't know whether they work or not, but B, there's an opportunity cost, right? That these patients who could be on normal, good medicines which have been proven, Instead, they're taking something which may be really harmful. So that's the problem, right?
So on one hand, they are missing on the benefit.
Yeah.
On the other hand, they are also at the risk of damages.
Correct, absolutely. And see, the problem is this is not like there is a difference between acute disorders and chronic disorders, right? For example, let's say I'm taking a medicine which is not working.
Right.
I would not know that for many years, right? It will take me a long time to really realize that, what I'm taking is probably harmful or not working. For example, अगर आपको fever होता है, if you take a herbal medicine, right, and it doesn't work, then you will take a paracetamol, right? Because you know that a fever to utra nahi, I'll take the medicine which works. So
then it is proven.
There and there it's proven, right? So that's the problem. So that's why these medicines tend to work in chronic disorders like arthritis and diabetes and coronary artery disease and all that. So because they have a long duration of
a lot of time to develop the complication, and till the time patient is exploited.
Already
all microvascular complication will take a lot of time, doctor. But doctor, is there a benefit? Is there a evidence of any of these medicines actually working for the patients?
So, very interestingly, there are institutes in our country which are working on generating evidence for that, right?
Right. So, like at CDRI, we have.
Yes. So we have certain, drug discovery process and all that, for alternative medicines. So there is a process which goes on. But unfortunately, and so far, whatever evidence I could dig up,
yes,
the evidence is extremely insufficient to prove anything, right? For example, there is a drug. I will not name the drug. I'll name it in my lecture tomorrow, but not on the TV.
Fine.
There is a drug which and our beloved Prime Minister was also promoting that medicine for diabetes. It's developed by one of the government institutes.
Okay.
So this drug and there's a lot of promotion which goes on. How many patients were enrolled in a study? They have one study. They have one clinical study, right? Compare that to number of studies you have for any drug, any metformin, SU, whatever, right? Be hundreds of studies. This is one study. That one study has 64 patients, just 64 patients, right? And of that, only 32 were receiving placebo and 32 were receiving the medication. Now, you tell me, is a drug which has been tested on just 32 patients, just on 32 patients across a billion population, will it be applicable or beneficial for a billion population? I don't think
you cannot scale up. You cannot scale up,
right? So that's the problem. So what I would say is, instead of spending money on marketing,
right,
why don't they spend money on doing better research? Why don't they do a research on thousands of patients, right? And say, why don't they do research on already existing medicines?
Correct.
And proving that the new medicine is probably better, right? Because this is how scientific development happens,
yes,
right? So spend money on good randomized control trial, involve more patients, and then if it really works, we are all happy to use it. But the problem is that it cannot be that these patients में मैंने दवाई test की, and I say that it is a Ramband for diabetes. No, it's not.
Those are tall claims.
Right? Which may not be substantial.
Because this is happening, sir, and people say that alternative medicine treat the disease from the root,
right,
which is not possible with the modern medicine. And this is a very common
yes,
thing going
this is
on.
a common misconception. This is a common cognitive bias, right? Very bizarre, because it is exactly the opposite. Okay. So sometimes to prove something wrong, you actually take a stand which is exactly opposite of what it is, and the people get so confused that they don't really, if you talk about treating from the root, now if you take the modern medicines like SGLT2 inhibitors, or if you take GLP analogs, right, they actually produce weight loss, they actually reduce insulin resistance. They, metformin, we know for so long that it reduces insulin resistance. That is one of the major pathophysiology of type 2 diabetes, right? So clearly we see, we prescribe these drugs every day, and people lose 2 kgs, 3 kgs in a month.
Correct.
Naturally, the patient's insulin resistance is going down, the patient's metabolism is improving. Modern medicine actually treat the disease from the root. Because they actually understand the disease process, right? That's the difference. Whereas you take these medicines which you don't know how it works. Even the people who have made the drug, some people say it's a natural DPP4 inhibitor, some people say it's like sulfonylurea. I mean, first, so आप ही समझो कि how does the medicine work, right?
Mode of actions are not known, sir.
That's not known. And just because it's herbal and just because it's been taken from natural ingredients, does it really mean that it's going to work? We don't know. Even to say that that for that matter, SGLT2 inhibitors has been developed from a bark of an apple tree, right? So even that is natural in that sense. For that argument, that is natural, right? Now, but I would not eat a bark of an apple tree because
treat my disease,
right? So rather I take the component which is the important one and then use that for the
which is
disease.
proven one, which is tried and tested in the clinical trials and everything. Right, sir, I understand that. So, sir, how does a clinical trial deal with a patient who requests information on alternative medicine for diabetes?
Okay, so clinicians, I would say, what they should do is, they should say that, you should say that I am not an expert in this. That is the first thing they should say, right? Now, I cannot give advice on alternative medicines because I am not trained to deal with alternative medicines, right? B, I can say that we can, look at the information which is available, right? Look at the data available. Then it's up to you whether you're convinced with that or not, right? So I will say that, according to my information, there is just one study with 32 patients, versus modern medicines have thousands of studies with thousands of patients. It's your choice to choose, whether you want to choose a medicine which has been proven only in 30 patients versus a medicine which has been proven in thousands of patients, right? And ultimately, we also need to inform people that what their cognitive biases are and how it is being exploited by these people, right? So, you make them understand that, if it says it's natural doesn't really mean that it's always safe. The worst of the poisons which are known are all natural poisons.
Natural,
right?
For example, arsenic.
Yeah. So natural doesn't mean that it is always harmless, right? So that's the important point. So that these things have to be kept in mind. Plus, as clinicians, we should probably invest more time in researching this, in researching why patients are attracted to this. What is the problem from our part that these people are attracted to something which is not unsubstantiated and not safe, right? So is there a flaw in maybe our way of counseling? Is there a flaw in maybe a way in which we deal with the disease? We need to introspect. These things need to be done, right? But the clear blanket answer to these patients are to say that, look, I'm not an expert in this, right? I would not give you an advice or something I'm not an expert in, right? Neither for or against, and it's up to your judgment and your call to take a decision or not, right? It's your decision, but you do it at your own risk. You don't do it, we will not advise, right?
And then prescribe the right thing.
Yeah, right, and prescribe the right thing. Always give the right advice. That's the most important.
Right. Thank you so much, Dr. Om Lakhani.
Thank you.
Thank you, everyone.
So, good evening everyone. I welcome you all to SPEEDCon 2020. So, today I talked about diabetic nephropathy. If we talk about diabetes in India, we all know that we have this dubious distinction of being known as the diabetes capital of the world. And if we look at the sheer numbers, there have been around 78 million people who suffer with this disease. And the problem is half of these people actually do not know that they have diabetes. So, as a physician from this country, I always strive to change this dubious distinction so that it is called at some point of stage or on some date, our country is called as diabetes care capital of the world. For that, we need a lot of efforts, not only from us physician side, but we know that the things have to be changed at the social level, at the government level also. So, like I told you, my topic was on diabetic nephropathy. We all know, if we look into the results of the biggest trial on type 2 diabetes, that is a UKPDS trial, where the participants were divided into two groups, into an intensive control arm and a routine control arm. It showed that just by intensive control of diabetes, it leads to around 30% reduction in microvascular complications. So, if we are treating diabetes aggressively early in the disease, if we are managing our patients' blood pressure well early in the disease, probably at least we can delay the development of chronic kidney disease in our patients. Good glycemic control and good blood pressure control, along with good control of dyslipidemia. So, these are the three ABC which I tell to my patients, that your A1C should be well controlled, your blood pressure should be well controlled, and your cholesterol should be well controlled if you want to stay away from the complications that are associated with diabetes. We all know that there are multiple agents that can be used for this, and probably the topic which was given to me today was the use of N-acetylcysteine, taurine and probiotics. So, these are the newer agents that have been used in the patients who have established chronic kidney disease. Most of, if you look at the guidelines, most of the guidelines currently suggest that if your patient is in the CKD stage 4 or 5, you can use the keto analogs or the ketosterol group of compounds to replace their protein intake for reducing their nitrogen load. If we know a little about the pathophysiology of diabetic kidney disease, it is mainly the hyperglycemia which is leading to injury of the glomeruli, which initiates an inflammatory cascade, and this inflammatory cascades, by injuring the glomerulus of the kidney, ultimately leads to the development of fibrosis, which leads to development of end stage renal disease. So, there are multiple agents, endothelin receptor antagonists, there are thromboxane antagonists that are currently in pipeline, and people are doing clinical studies on these agents, and most of these studies are in stage 4, stage 3 or stage 4, and probably will be having some more agents after a few years. Coming back to the ketosterol group of drugs. So, ketosterols are the keto analogs of the routine amino acids which our patients use. So, we all know that in a diabetic patient, it is the protein degradation in the intestine which leads to development of uremic toxins. So, it comes logically to us that if we are able to reduce the protein intake of our patients, it will lead to reduction of these uremic toxins, and probably the progression of CKD will also halt. But the main limitation factor with a low protein diet is, once we reduce proteins to a very low level, it leads to negative nitrogen balance and leads to development of cachexia and malnutrition in the patient, which is actually detrimental to the patient, and most of the patients are not able to tolerate these very low protein diets. So people came up with an idea that if we are able to replace the nitrogen compound of these amino acids and with a keto group, probably will reduce the nitrogen load of the patient. So these keto analogs do not contain the nitrogen compound, which is replaced by the keto group. So during the protein formation in the body, these keto analogs take a nitrogen atom from urea that is increased in patients with CKD. So by using the nitrogen from urea, it leads to reduction of uremic toxins and probably reduction of further damage to the kidney. And by replacing these essential amino acids, we are able to reduce the protein in the diet, and the patient still does not develop cachexia because they are getting their essential amino acids through the keto analogs. So if we look into the various studies that are available, there is a meta-analysis available which did show some improvement in creatinine. So these are very small studies that are available. We require large randomized controlled trials before we can routinely propagate the use of these ketosterol group of drugs. And probably as of today, the recommendation does say that if your patient is in CKD stage 4 or 5, there you can use ketosterol with a low protein diet which contains a protein restriction to the amount of 0.6 gram per kg per day. So this is where keto analogs can be used. So the next drugs which are coming into the pipeline are N-acetylcysteine and taurine. So N-acetylcysteine and taurine both are anti-inflammatory agents. Both have been used in patients with renal disease to reduce the inflammation and to increase the blood flow of the kidney. And we all know from our routine practice that in a diabetic patient or in a patient who has renal compromise and he has to undergo any of the imaging studies which uses contrast media, these patients should be given N-acetylcysteine for 3 days, because N-acetylcysteine actually reduces inflammation in the kidney and it protects the patient's kidney against the damaging effects of these contrast media. So taking that theory further, people tried to use it in patients with diabetic chronic kidney disease, and the study in the animal models, mostly the rodent models, have shown that a combination of N-acetylcysteine and taurine can be helpful in reducing the inflammatory biomarkers, and it can actually reduce creatinine levels also. It reduces proteinuria in rodent models, but we do not have any human studies available. There was one small paper from India which did show that it improves the level of inflammatory biomarkers like TGF beta 1, and it can be used in patients with microalbuminuria. But another study failed to show any improvement in these parameters. So still we do not have any large randomized controlled trials which have shown the beneficial effects of these drugs, and probably these drugs can be safely be used as just as an adjuvant therapy as of now. So the last drug which I discussed about today was the probiotics. Probiotics, the role of intestinal gut microbiota, as we all know now, most of the studies have now shown that intestinal microbiota may be responsible for the development of type 2 diabetes, they may be responsible for the development of obesity, for the development of metabolic syndrome, for the development of PCOD. So there have been multiple studies that have shown that it is the change in the intestinal microbiota that leads to development of metabolic complications. So if we look into the pathophysiology, there was a paper which showed that with high fat and high carbohydrate diet, there is a shift of intestinal microbiota. It's a shift towards a gram-positive bacteria. With increase in these gram-positive bacteria in the intestinal milieu, there is increased development of inflammatory molecules. These inflammatory molecules are easily able to translocate through the intestinal wall. So once these inflammatory molecules translocate to the crosses the blood intestinal barrier and they reach inside the blood vessels, they lead to the development of inflammation in the body, and this inflammation is responsible for development of insulin resistance, which leads to obesity, type 2 diabetes, PCOS, metabolic complications. So this was the pathophysiology study which showed that yes, change in gut microbiota can lead to development of all of these metabolic problems. And if we look into the papers from bariatric surgery, so it has also been shown in these papers that bariatric surgery actually shifts this microbiota again towards in favor of gram negative bacteria. So again the balance is restored and the pathogenic process is taken care of, and this is what leads to weight reduction and improved insulin sensitivity in patients of bariatric surgery. So this has been one of the concepts, and same has been shown with the newer agents like GLP-1 receptor agonists as well. So there are multiple studies available on intestinal microbiotas with these agents. So using these as a background, some people thought that yes, change in probiotics or giving the patients probiotic will improve the patient's gut microbiota, and this will improve the patient's inflammatory cascade, and this will slow the progression of chronic kidney disease. If we look into the trials that are available, so there is a large meta-analysis that is available in which it looked into the studies that have compared probiotics with placebo. And in this meta-analysis, the meta-analysis failed to show any improvement in patients who were on probiotics. It did not show any improvement in serum creatinine or blood urea nitrogen in these patients. But it did show that by giving probiotics, we are able to reduce specific uremic toxins like peak recyl sulfate. So there are some benefits of giving probiotics to the patient, but still we need some large studies, and there was a recent paper which failed to show these improvements in the patients. So if I like to conclude my session, I believe that still many drugs are in pipeline which may help us in managing patients with chronic kidney disease, with diabetes in future. But today the most important treatment for managing diabetic nephropathy is prevent development of diabetic nephropathy by good glycemic control, by good blood pressure control, and by good lipid management. And if your patient has developed diabetic nephropathy, probably ketosterol, N-acetylcysteine, taurine, and probiotics may be useful just as an adjuvant therapy in your patients. Thank you. So, good evening once again. Now I have with me Dr. Suresh Damodaran, who is a consultant endocrinologist at Ramakrishnan Hospital in Coimbatore, Tamil Nadu. He is also an executive council member of Endocrine Society of India, and he is currently Vice President, Tamil Nadu Endocrine Society. I welcome you, sir.
Thank you for hosting it.
We have many new medications, modern diabetic medications that are available for our use in our patients. What particular advantages do you think of these modern diabetic medications? What are the particular advantages specifically in Indian patients?
I think the current modern medicines, how it different from the old ones, or really the previous medicines had the challenge of weight gain and hypoglycemia, and the current modern medicines, if you can take incretin or SGLT2 or gliptin, it's got an advantage of not causing hypoglycemia that much, which is the key thing in managing diabetes. And along with that, the weight gain aspect, we got in fact a good advantage of having a weight loss, and that is the major shift of diabetes management from the days in the past. Yeah. So this is the new drugs have given light about the cardiovascular safety as well, with FDA needing to bring in more data for cardiovascular. So these drugs are not only good in that aspect of not causing side effects, but also cardiovascularly safe, and that's the difference that I see.
Thank you, sir. Today is a world of, I believe, social media, and we live in an age where we are more glued to our mobile phones, or we are more attached to the social media than we are actually interacting with the people. Do you think there are any advantages, particularly if we are talking about managing a diabetic patient of social media?
Actually, it was one of my talks, but the talk was just about social media for the whole lot of physicians, whether we should have it or not. For the diabetic doctors specifically, I mean, as a doctor as a whole, it's got an advantage of reaching to the public and also to your colleagues in a rapid pace, and you can get an interaction within no time. And so by doing that, the message that you want to convey will go in a rapid pace, and also you can also, for example, Dr. Sanjay Kalra started WhatsApp group, and that is linking us with diabetes and endocrinologists from Afghanistan. So the advantage for them is they look upon us for all the case-based discussions. So here you're not only talking to the colleagues, but also solving the problem for the people who look upon you. So I'm giving you an example of a country, but it can happen with the rural thing. So the healthcare improvement will be phenomenal when it takes it to the right direction. And coming back directly to diabetes, yes, you can do diabetes management through social media, but there are a lot of things that needs to be maintained, and that was the key talk. I mean, a lot of other countries have got the guidelines. For example, General Medical Council in UK, or Canadian guidelines, or an American guidelines, or Australian. They got, for the doctors, they got an excellent sort of guidelines for how to be in social media, whether the confidentiality, for example, the defamation, and how to be professional and how to be respecting the other doctors. So those are the things that need to be streamlined in India in a big way, because we are just going in a rapid pace digitally. So that's my worry, and we got a right team of change. MCI has changed a lot, and hopefully we'll get more input from that.
So like you were saying, everything has two coins. The coin has two sides, I believe. So like social media has certain advantages in the form that you can reach to millions, but what disadvantages do you believe? What are your areas of concern? Where do you think as a physician I should be, or my colleague should be careful?
See, you got a good question there, but so everything has got another side to it. So we see the main advantage aspect of it, and people getting immediate benefit. It's like going in an Indian traffic and reaching home within a minute. So we see the one side of it, but there are a lot of disadvantages we should be careful about. The thing is mainly the confidentiality of the patient data, and that is almost up in the air with lot of social media thing, even though it's one-to-one interactions, but sometimes it can be stored for a very long time, and it can cause a lot of things that you don't want it to happen. So the patient confidentiality is the big thing that comes first, because it affects the patient safety. And then the second is defamation, because in social media anybody can take content out of the context and then they can go behind you. And third thing is the patient-doctor relationship. It will be a blurry thing, because I'll give you an example. Some doctor gets a Facebook request from a guy, the name is very, very familiar to the doctor, but the DP profile is a dog of his own. So it is not, he doesn't know who it is, but he accepts it. And then this guy comes into Facebook thing, and this guy is turned to be his patient. So he's coming into and asking, sir, can I come on Monday for your appointment? And what the swimwear you're wearing in for Maldives, what you're wearing is just beautiful. So the patient-doctor relationship can be blurry if you just go into the social media in a big way, and also it can have a negative impact for health as well. For example, the vaccines in developed countries, a lot of hype about just going against the vaccines, and the kids got affected, the immunity got affected, and we're just seeing epidemic of other viruses that should have controlled better. So yes, it's got its disadvantage, but as I said, the guidelines has to be brought in properly, and then we should also try to follow with our ethical values. The guidelines can be there, but the ethical thing of just being professional and respectable of your colleagues, maintaining the patient confidentiality, and you should also think about defamation, which will be a big thing in future in India.
Yeah, so rightfully said. I believe these are the real things that we should be careful as care providers. He's very rightly pointed out that it is our ethics, and there has to be few guidelines also, which should form the norm for this. So is this your first time on SPEEDCon, in SPEEDCon?
SPEEDCon first time, yes. Last time I couldn't make it, but this time I think I planned in a way that I could attend it. But thanks for inviting, and it's an honor to be here.
It's an honor for us to be, for you to be here, sir. And I extend my wishes that your stay is comfortable over here.
Absolutely.
And you enjoy.
Already I'm enjoying it. I think it's a wonderful experience. Thank you.
Okay, thank you.
Thanks.
Hello, I am Dr. Sushil Kotru. I am working as consultant and head department of endocrinology, Max Specialty Hospital, Bathinda. I have with me dietitian Leena Sharma. She is our head department of nutrition, working with me in my department. Today we are going to talk about comprehensive diabetes care. As all of us know, controlling blood sugar is only a part of story of diabetes management. We have to provide 360-degree diabetes care to the patients. Ours is a department which provides comprehensive diabetes care. For that, we have a proper team of diabetes educators, counselors, and dietitians. We are doing that care. And I have a podiatrist with me and other technicians also. And I know, and all of us know that diabetes education is the cornerstone of diabetes management. There are lots of myths about diabetes, and we'll try to correct these myths also. We always organize a session for diabetes patients, and the diabetes management starts with diabetes education. She imparts diabetes education for the patients, and after going through registration, all the new diabetes patients have to go through that diabetes education. And about the diet part also, all the patients and attendants have to attend that education session, and the gross diet plan has to be explained in detail to the attendants and the patients. We want to throw some light about the diet part, what type of diet the general diabetes patients have to take. We explain them. There is no diabetes diet. This is basically a healthy diet plan. Yeah. Not only the patient should follow this diet plan, all the members of the family should follow this diet plan. Then only the diabetic patients will also follow the same plan. You want to say something about that?
So diabetic patient need to control his or her blood sugar levels. So as Dr. Kotru said, it is the diet for even for a normal person. So what we do, we divide diet into 3 categories. वैसे तो diet is always individualized, but if अगर उसका कुछ basics अभी अगर लिया जाए, तो we divide it into 3 categories. That is red category, yellow category, and green category. Now, first of all, if we talk about red category, in this category, there are foods which we need to avoid. Like foods with high glycemic index, food with high glycemic index, like simple sugars, whether it is jaggery, sugar, honey, or any squashes, bakery products, cake, pastries, chocolate, jam, jellies, and high glycemic index foods like mangoes, banana, chiku, lychees, we have to avoid. And refined food items made from maida or refined flour, like patties or bakery products, all bakery products we need to avoid.
Ice creams, cold drinks, pastries, cakes, jams.
That also.
And we should also avoid red meat because it is rich in
fats.
Highly saturated fats also. And just want to compare with all the traffic signals.
Red means stop. We need to stop here before taking these foods.
And the yellow category?
The next category is yellow category. In this category, there are some foods which we can take, but in moderation. Like if you are consuming chapati or rice, that need to be in moderation. This shouldn't be like this. If you are feeling hungry, then you will take 4 to 5 chapati at once. Or
just to interrupt you, about the chapati and rice, which is better for diabetes patients?
Rice is having high glycemic index if we compare it with the wheat. But we do contain other minerals and vitamins and also fiber. But there's nothing like a diabetic person cannot eat rice. He can eat rice, but he have to add extra salad or extra fiber with it.
Vegetables to that, so that it can lower down the glycemic index.
It can be in the form of vegetable rice. It shouldn't be like biryani or fried rice. It should be steamed or boiled rice with extra salad or any source of fiber he can consume with it.
About the non-vegetarian food?
Non-vegetarian foods, one can take eggs. Egg whites are recommended. Yellow ones are not recommended because as it is high in cholesterol. And about flesh foods, it should be in roasted form or in grilled form, not in fried form. There's some patient asks us, can we eat fish? We say yes, you can take. But what they do, they eat fish pakora.
So it is better to eat grilled fish or
it can be taken in grilled form or in curry form. but not
Some
in
fruits
fried
can
form.
be taken. Diabetes patients can take fruits up to 150 to 200 grams, and which better or which fruits they should take?
Like apple, papaya,
Hmm.
guava, pear, strawberries,
So
melon.
these
They
fruits
can
can be
consume.
taken
Yes,
by
they can
diabetes
consume.
patients. It's not
Yes.
like that.
But it shouldn't be like this, ki haan, they are eating half kg of fruit at once. It
200
should be
grams.
like 100
So
to 150 grams.
these are the yellow categories, the yellow
Please.
signal, yellow traffic
Yeah,
signal in
pulses,
moderation.
pulses, non-veg foods, milk products like curd, lassi, and milk. It should be taken in moderation only.
And milk, which milk is that should
Skimmed
be
milk.
skimmed double
milk,
tone
yes,
milk is
yes.
better.
Double
Should-
tone milk,
and
yes.
the quantity has to be in moderation. And the green signal, which can be taken in
I guess one can go for green.
extra quantity.
Yeah, there are some patients. They say कि हाँ, like we are habitual of taking 4 to 5 chapatis at like in one meal, and you are saying कि you have to control your weight and you have to keep your sugar levels in control. So you can take 2 to 3 chapatis only. But I cannot feel satisfied with this amount. है ना? What else I can take? Like I feel hungry all the time. So there are some food options which they can opt for whenever they are feeling hungry. Like they can take extra salad, they can take cooked vegetable or sorted vegetables.
They should
thin
start their
buttermilk.
meal with salad,
Yeah.
with boiled
Yeah,
vegetables.
that is better. They can also go for clear soups without that should be like without oil or fat, है ना?
And
They
you
should
see the
avoid all
Indian
kinds of
culture, we are fond of tea, lot of coffee also. People prefer to use
Yeah.
coffee these days. It's better to take black coffee,
black coffee,
green
black tea.
black
Like
tea.
most of the people are fond of tea or coffee, है ना?
And they're concerned about their weight
They-
also. The
yes.
females are very concerned about the weight also.
They do say कि हाँ, they consume like 10 to 15 cups of coffee in a day. So it shouldn't be like a milk coffee, है ना? It should be like they can take in the form of like green coffee, green tea, black coffee, black tea. That is a better
So
option.
this was a gross teaching about the diet, what the type of diet, and regular exercise is very important. So we're talking about comprehensive diabetes care. So a diabetes patient should know that in addition to following a proper diet plan, exercise plan, following a proper medical treatment, in addition to that, once in a year, a diabetes patient has to follow certain instructions, has to go for some investigations. The fundus examination, that is retina checkup, is very important. Dental checkup is also important for these patients. And thyroid checkup for some patients who have dyslipidemia, or it's very common in our society these days. In diabetes patients, they are at risk of having thyroid disorder at the same time, mainly type 1 diabetes. And those patients who have some symptoms of cardiac disease, like dyspnea on exertion or angina on exertion, or feeling weakness on walking, so they should also go for cardiac checkup. Food checkup is very, very important, and annual inspection of feet, going for foot nerve checkup, very basic checkup, blood flow in your feet checkup. It should be done by a center who is a concerned person. A basic checkup has to be done by the doctor. The food checkup is important. Urine albumin creatinine ratio, checking for urine protein is also important, in addition to kidney function test or renal function test. These days, NASH or NAFLD is also commonly seen in diabetes patients. So checking for liver function test, going for a fibroscan or ultrasound abdomen is also important. So just controlling blood sugar is only a part of diabetes management. So at the same time, now we know that diabetes is a syndrome. So you need comprehensive checkup of diabetes patient. For that you need a comprehensive care center so as to look at all the complications of diabetes. So first we should try to prevent diabetes, work on that, follow a proper lifestyle, follow a proper diet plan, follow a proper exercise plan, start from the childhood only. So prevent diabetes should be our main motto. Once the patient has diabetes, control your sugars, control your blood pressure, control your lipids, prevent the complications of diabetes. Once the patient has the complications of diabetes, try to prevent end-stage complications. And once the patient develops all the end-stage complications, it becomes a very, very costly disease, and the patient loses everything financially and socially also, and the family has to suffer a lot. So our main message is, so diabetes management needs comprehensive care. We should have more of comprehensive diabetes care centers, and our department and our center is ready to help more and more primary care physicians and doctors who want to come and who want to get skill training at our center and to develop these type of centers, or we are ready to share our project with them. Thanks a lot, the Torrent people who have the division also, and who has given this opportunity to us to share our ideas. Thanks a lot.
A very warm hello to all our friends. I am Dr. Gagan Priya, consultant endocrinologist at Fortis Hospital and Ivy Hospitals, Mohali. Today we will discuss a very novel concept, and this concept is called glycemic happiness. Now, what do you really mean by glycemic happiness? I'm sure many of us wouldn't really have heard this word before. What exactly is happiness? We do understand that happiness is a personal construct. It varies from one person to the other. It varies from one moment to the other. And glycemic, we basically mean is glucose control or related to glucose control. So when we say glycemic happiness, simply put, this is creating a state of happiness in the diabetes care environment. Now, in modern times, we always seem stressed. We are in stress related to our work, we are in stress related to our jobs, profession, family life. Time is a constraint at all times, and yes, any disease process also creates significant stress, especially if it's a chronic disease that takes a lot from an individual. So there is need for, when it comes to diabetes, need for diet management, regular physical activity, which may be time consuming itself, and then there is need to adhere to medications over a long period of time. It's not a 2 weeks course of an antibiotic that you have to get over with, but you have to commit to these changes throughout your life, and there's always that looming threat of complications, even despite good control of all parameters. So when we talk of health, what is health? Health really is not merely an absence of disease. Otherwise, let's say somebody who's a chronic disease could never be healthy. But now in diabetes, we understand that people can live well with diabetes. In fact, we don't really call them as suffering from diabetes, we say living with diabetes. So health is a construct of biological, emotional, psychological and social well-being, wherein a person can fulfill all his or her responsibilities and social interactions and also have a good quality of life, a happy quality of life. So applying this concept of health to diabetes care, we do understand diabetes can cause a lot of distress in individuals, but our focus is how can we make these individuals happy or live in what is called as equanimity, a sense of euthymia, that everything is well in the world, even despite of all the problems. So when we talk of happiness, it is not just the absence of misery, but a more positive construct that a person who is living with diabetes feels satisfied or feels, confident in their ability to take care of themselves and also fulfill their social personal responsibilities, can do what is required for self-care. So they can adhere to the dietary advice as well as the lifestyle modification that's required. They can take medications over a long period of time, and they can also, of course, avoid or prevent complications from happening. And if these complications do happen, they have ways out of, or they're able to manage those complications well. So when we define glycemic happiness, it is a state of emotional, physical and mental well-being as well as psychosocial well-being. We should add that social concept also in persons living with diabetes, which fosters in them an ability to live well and to a satisfactory level, as satisfactory as any person who does not have diabetes. Now, how can we create diabetes happiness? When we talk of creation of diabetes happiness, let's look at the role of both the person with diabetes, his or her family, and the healthcare provider. These are the three pillars of management or care for an individual with diabetes. And at the crux, of course, the center of this, the strongest pillar is the individual with diabetes. I would differ from saying patient with diabetes, but the individual person who is living with diabetes. So they have to be able to learn, as well as they have to be empowered with education, information, and that kind of confidence that they can take care of themselves, they can take these medications, they can adhere to lifestyle advice and so on. So empowerment of the patient and of course instilling a level of confidence in them is important. A very important side pillar would be the family and friends, because fortunately in our country we live in a society where families still take care of themselves, of each other, they are there for support. So empowering the family also, educating them, ensuring that they're there for support and that support is constructive. They're not relatives who are giving, spreading myths and lies about diabetes care management, but they're involved in the decision-making process itself. The third, of course, a key pillar is ourselves, the healthcare providers, and that includes the doctor who's caring for the individual with diabetes, but also includes the nutritionist, maybe an exercise trainer or a gym trainer who's involved in diabetes care itself, or even other specialities. Sometimes you might need a psychologist or a psychiatrist, or maybe a person who has kidney disease needs a nephrologist or a cardiologist for somebody who has cardiac disease. So all of these form the healthcare team, which also is an important pillar. But a very important fourth pillar that ensures glycemic happiness is communication between these three pillars. So these three pillars cannot stand in isolation if there is not a healthy communication between all three of them. So the healthy communication is a responsibility of the healthcare provider to initiate, and then of course the family and the individual with diabetes also has to participate equally in the shared decision making process, as well as in adhering to whatever advice is given in the clinic. So I think this is on the outlook, this might look as a very utopian concept that we are looking at something which maybe it is not achievable, but together we can. So if we are working, joining hands together, we can create glycemic happiness in our individuals who we care for, in their families, as well as, of course, a happy patient makes a happy doctor. So I think the carry home message is that happiness is, of course, our responsibility, both for the individual we care for and also, of course, our own happiness is our responsibility. Thank you so much.
Hello viewers, welcome to Speed TV. It is a pleasure to introduce to all of you Dr. Sunil Kota, eminent endocrinologist from Berhampur. He is going to talk to you about the keto diet today. Hello Dr. Sunil, my first question to you, what is the keto diet?
So before going on to the topic, let me introduce my friend as well. He is Dr. V. Srinagesh, eminent endocrinologist from Hyderabad, and he is one of the executive board member of the Endocrine Society of India as well.
Thanks a lot. Too much of eminence around.
Yeah.
So, coming to the crux of the issue, your take on the keto diet. What exactly do you think is the keto diet?
Yeah, actually, when we talk about management of obesity, the major thrust is on diet restriction, which contributes to 70% of the chances. And in the process of weight loss, there are some diets which offer us slow weight reduction, slow and sustained, and there are some extreme weight reducing diets. Out of those, keto diet is one such, where the carbohydrates are restricted to bare minimum, and different studies project it at 5 to 10%, and the predominant chunk of diet comes from the fat, contributing to around 70 to 75%, and the rest amount goes for fat. So it is a form of diet where the carbohydrates are at bare minimum and the fats take the upper hand.
What do you think is its mechanism of weight reduction? How does it reduce weight?
Yeah, the mechanisms are manifold, but the initial phases, the predominant mode of weight loss is water loss or diuresis, because amongst three macronutrients, carbohydrate is the one which holds on to water for a very long period, and when the carbohydrates are reduced, there is a sort of diuretic effect. So initial weight loss is due to water diuresis, and then comes the lipolysis. There is reduction in lipogenesis. At the same time, there is a satiety effect of protein, so that the patients won't feel hunger after taking such a diet, and there is thermic effect of protein as well, which comes into the picture.
So, what is your take on the current literature in obesity? Do you think it supports keto diet, or it is on the whole against keto diet?
Yeah, so there are studies supporting both the ways. Like, there are some studies which say it is really beneficial in terms of weight loss, and some studies which talk us about the better control of A1C with better control of weight and other parameters like lipids, blood pressure and all. But there are counter views as well. There are different schools of thought which say probably it is not the fact. But as of now, looking at the entire set of literature, I can say for short term weight loss, the current literature published in 2019, the lipid journal, it states that probably up to a period of 12 to 13 months usage, it can be definitely recommended, but it cannot be used for very long term, because most of these studies are less than 2 years duration, and there are a number of other pleiotropic benefits, but again there are different schools of thought. Some say it increases lipids, some say it reduces lipids, but as of now, for short term weight loss, definitely it is one of the good options.
What are the side effects of this keto diet?
Yeah, this is one very important aspect which we need to talk about, because there are some short term side effects and there are some long term side effects as well, which hampers its adherence and sustainability. The short term side effects include constipation, halitosis, weakness, muscle cramps, then sometimes there can be potentiation of DKA, keto rash, keto flu. These are some of the short term side effects. The long term, because of there is calciuria, there would be bone loss, there would be excess formation of uric acid, which can give rise to kidney stone formation as well. There are chances of hypoproteinemia as well, because of association with protein losing gastroenteropathy, and there are chances of renal involvement in this form of acute kidney injury, which can be due to dehydration, and at the same time there are chances of increased occurrence of mortality because of the increased intake of animal protein. So these are on top of this, there are chances of vitamin and mineral deficiency, which can also be playing a significant role in its lack of sustainability results.
So what is your final take home message about the keto diet? Should we do it or should we not do it?
Yeah, so I was a part of the debate, so I would definitely tell that as of now, from a neutral point of view, for short term weight loss, definitely it is of use. So probably the current lipid guidelines also suggest use it for a period of 12 to 13 months, give a break, come to a dietary pattern where there would be restriction of calories and there would be reduction in the portion size, and again after some period of time you can go back to keto. But as of now, because of lack of long term data, because of the short term and the long term side effects, it would not be my first choice, as supported by the several guidelines as well.
Sir, thanks a lot for a very lucid explanation about the keto diet.
Done? నేను అడిగేస్తా మీకు.
What is sir?
Welcome to Speed TV, and I have in front of me a close friend of mine, hardcore academician I would say, Dr. V. Srinagesh, who happens to be executive committee member of the Endocrine Society of India, and he currently practices at Hyderabad. Welcome, Dr. Srinagesh.
Thank you, Dr. Sunil, and to reciprocate the introduction, I am really happy to be interviewed by Dr. Sunil Kota, a very well-known endocrinologist from Barampur, and I am really glad that he is interviewing me today.
So, let us come to the topic. What exactly do you mean by saying intermittent fasting?
Intermittent fasting is one of the recent diet fads which has really come in a big way. Basically, this involves spending at least some time of the day in a fasting state. It can be where you do an intermittent fasting for up to 18 hours in a day and eat only for the rest of the 6 hours, or it can be an alternate day fast where you fast on one day and you have an ad libitum feeding on the other day, or it can even involve fasting for 1 or 2 days in a week. But the most important point is, for at least 16 to 20 hours in a day, you will try to spend it in a fasting state, under the impression that this will help your blood glucose levels and also help you lose weight.
So, nice to know that. Is it really a new trend that has come in, or it is there since long?
Intermittent fasting is as old as mankind. If you look at any religion, every religion has had some kind of intermittent fasting. Of course, as far as Hinduism is concerned, every day can be a fast day. We have the very well-known Ramadan fast for the Muslims, Lent for the Christians. Buddhists have their Vasa, which is again a 40-day fasting period, and even the Jews have their Yom Kippur fasting day and also other fasting days. It's been there since the onset of mankind. In fact, in the early 1920s, before insulin was discovered, restrictive caloric intake or fasting was one of the ways of controlling your blood glucose level, so that you did not go into diabetic ketoacidosis. In fact, people were put on very low calorie diets, almost 600 to 800 calories per day, to the point of absolute starvation and wasting, in the hope that this would not raise their blood glucose levels and eventually lead to ketoacidosis, which at that point of time was a universally fatal disease.
So good to know about its history as well. I was fortunate enough to be a part of the audience to your wonderful presentation. It was really lucid, and I would like to let our audience know about its potential benefits. Are there any?
There are many benefits. There are many small studies which have been done about intermittent fasting, about the various regimens of intermittent fasting, and all of them universally have shown some amount of benefits. The most important benefit is with weight loss. You can lose up to 5 to 6 kilos of weight if you are on an intermittent fasting diet for a couple of months. There is always a reduction in your LDL cholesterol levels, a massive reduction in your triglyceride levels, a decrease in your blood glucose levels, as also an improvement in your insulin sensitivity, as is measured by HOMA-IR and the various indices of insulin sensitivity. Your adiponectin levels go up, and the other adipocytokines which increase insulin resistance like resistin and visfatin go down, and also inflammatory markers like interleukin 2, interleukin 6 also decrease with this. And not only that, not only is there a reduction in the LDL level, but also the LDL particle size also increases. It progresses favorably from a small dense LDL particle to a slightly larger, more buoyant LDL particle, which is considered to be less atherogenic. Even as far as cognition is concerned, there have been many benefits with cognition. This has in fact been touted as a cure for Alzheimer's disease, as also for Parkinsonism. There are also significant cardiovascular benefits in diabetics and also in smokers. And contrary to what people expect, you don't really lose a lot of muscle, especially if you combine your intermittent fasting regimen with exercise. Overall, there are not many adverse physical outcomes with intermittent fasting. There are many benefits which have been recorded in a majority of studies, which have been done with whatever kind of regimen. Whatever the kind of regimen, you generally always have some benefits with intermittent fasting.
So as we listen to you, there are a lot of benefits associated with this particular type of diet. So why are the doctors not prescribing it on a routine basis? What's your take on that?
There are two main problems with intermittent fasting. One is the sustainability factor. Whenever you are on a diet, be it the keto diet, be it the intermittent diet, or be it the Atkins diet has to be practical and it has to be sustainable. If you are on a fad diet, then more often than not the question of sustainability comes in. A diet has to be maintained for the rest of your life. You cannot have a trend where you are on a diet for 3 or 4 months, go off the diet, then you again start piling on the pounds, and rather than having true weight loss, which is defined as losing more than 10% of your body weight and retaining it for at least 1 year, you just pile on the pounds after 3 or 4 months. This leads to a phenomenon called weight cycling, which is actually in fact more deleterious than what would have happened if you had not lost any weight in the first place. And also because people who are on intermittent diet report extreme hunger, decreased work concentration, and also increased work pressure. The other problem with the keto diet, with the intermittent fasting, is the fact that you do not have large data sets. We have many studies, but almost all of these studies have been done in 10 people, 15 people, 20 people for a period of 2 months, 3 months. The longer studies have actually shown that as the time goes on, the benefit starts coming down with this kind of a regimen. And at the end of 1 year, you're probably left with no net weight loss, even though you might have some benefits in insulin resistance. So without having concrete data and large scale data, as a medical society or as a medical entity, we cannot recommend intermittent fasting to our patients at this point of time.
So very nicely depicted. So after listening to all these points, what's your final take home points? Would you give a thumbs up or a thumbs down?
I'd rather not show any thumbs. As far as intermittent fasting is concerned, proof of concept studies are pretty good. There is a significant amount of benefit. There is a cultural benefit and a cultural connect with intermittent fasting. On the other hand, issues like hunger, decreased work performance, and lack of evidence are very much there. If you are doing an intermittent fasting for religious reasons, please go ahead with your intermittent fasting. If you want to do your intermittent fasting for obesity, you can do it for short periods of time. There is nothing to contraindicate it. But if you want it for a slightly longer period, as for decreasing your diabetes medicines, or if you want to go in for diabetes reversal, the jury is still out on this. We cannot give any concrete recommendations right now. Probably larger scale studies and more significant directed research might provide us with the answer. But at this point of time, intermittent fasting should remain one of those fad diets about which we have discussed, and cannot be brought into the mainstream of diabetes and obesity management.
Thank you so much for those wonderful insights.
Thank you. Are you
Sanjay.
Yeah, so today we are going to discuss with Dr. Jay Chordia. He is renowned endocrinologist of Rajasthan. He is DM endocrinologist and he is director of Dr. Jay's Diabetes and Endocrine Center. He also associated with the Paras Hospital, Udaipur. Myself, Dr. Sanjay Saran.
I must introduce rather Sanjay. Sanjay Saran is my junior definitely, but he is a very good consultant endocrinologist at Pink City, Jaipur, Rajasthan, as serving as an assistant professor in Department of Endocrinology, SMS Medical College.
Thank you for your kind introduction, sir. So today we are going to discuss regarding diabetic nephropathy. So first of all, I would like to ask sir, can you highlight something regarding diabetic nephropathy?
Okay. So diabetic nephropathy, there is a two terminology. One is diabetic nephropathy, one is diabetic kidney disease. So diabetic nephropathy is different from diabetic kidney disease when you have a clear-cut evidence that this nephropathy or this CKD is because of diabetes. That should be labeled as diabetic nephropathy. So in routine prescriptions, what we see, a patient who has diabetes and having a creatinine of slightly on a higher side is labeled as diabetic nephropathy. It should not be like that. It should be a diabetic kidney disease. What is diabetic nephropathy? When the diabetes is causing CKD and there is a histopathological confirmation of the same, that only pathogenesis behind this nephropathy is diabetes, then we label it as diabetic nephropathy. One. So this is pertaining to the definition. Second important thing is that what originally is diabetic nephropathy, whether a creatinine elevation is diabetic nephropathy or not. So there are various stages to differentiate diabetic nephropathy from stage 0, 1, 2, 3, 4, 5. That means whenever we get a routine screening, a urine routine of a patient or a urine microalbumin, which is a very sensitive marker for initial detection of diabetic nephropathy, and we see which stage as incipient nephropathy, where the microalbumin, the urine microalbumin comes out to be more than 30 microgram. So that stage is labeled as incipient nephropathy, and according to the stages of albuminuria as well as the CKD stages according to estimated GFR, we label the patient at various stages of diabetic nephropathy.
Okay, so how we can prevent the diabetic nephropathy in diabetic patients so that we can lessen the burden of cardiovascular disease also in diabetic patients?
Very good question and a very pertinent question, because prevention is always better than cure. And when we talk about the prevention of diabetic nephropathy, because diabetes is the main source of many disorders, maybe cardiovascular disorders, and Sanjay is saying that diabetic kidney disease also causes major cardiovascular morbidity and mortality. It is the biggest leading cause of ESRD, coronary artery diseases, as well as atherosclerotic disorders, maybe stroke. And for prevention, what is the important message pertaining to a diabetic patient? The first and the foremost, definitely, diabetes, once detected, a patient is in havoc. That okay, my diet is being restricted, my lifestyle is now to be very good, and I can't do my job and multiple other things. So that havoc should be cleared from the brain, that no, once you are a diabetic, that doesn't stand, don't haphazard anyway. Just take proper guidance, a proper treatment, because many of our Indian patients, what they do, once you are labeled as diabetic or they get a random sugar and which is on a higher side, they avoid doctors, they avoid the consultation, they take a diet part, a lifestyle part, which I don't say is a bad thing, but that should be under guidance, and they also approach for alternative medicines till the stage comes where they have good symptoms of complications in the form of UTI, in the form of genital infections or skin disorders, where they come to an endocrinologist oblique diabetologist for diabetes consultation. So the first point would be that once you are labeled as diabetes, because type 2 diabetes may come with complications also, and type 1 diabetes definitely doesn't come, but still type 1 diabetes comes with diabetic ketoacidosis. So first and the foremost, as soon as you are diagnosed as diabetic, consult a good doctor in the form of endocrinologist and ask him that, doctor, how can I go for good diet and lifestyle oblique medical therapy so that my diabetes complications are prevented? And the doctor will perfectly guide you on your dietary part, because there is nothing like a word that now you should stop meetha, you should stop sweets, you should stop sugar. So this is all rubbish. Whether it is diabetic nephropathy, the talk which I have given, where you have to restrict the protein source, which I will talk later. So first and the foremost is the counseling part on diet, on lifestyle, and followed by good adherent therapy, medical therapy in a proper manner, so that you can prevent the end organ complications, because diabetic nephropathy not only comes via sugar, it is associated with say hypertension, because many diabetic patients are associated with hypertension. So diabetes should be controlled, the blood pressure should be controlled, and multiple comorbidities has to be targeted simultaneously, so that the patient can prevent the end organ complications of diabetes.
Thank you. Sir, can you highlight some diet that which diet should we take to prevent the nephropathy in type 2 diabetic patients?
A very pertinent question, because in Indian scenario, when we talk about our farmers, what I have presented, rather there is a database now that because India is becoming rich on the rural part also as well as the urban part of. So first and the foremost, as soon as you are labeled with diabetic nephropathy or CKD, the doctor will tell you protein restrict, strictly protein restrict, no fruits, no vegetables, nothing like that. So is it so? I don't think it is like that. The first and the foremost, a doctor should not become a dietitian. The patient should be counseled via a proper dietitian. There should be a proper assessment of his daily caloric intake, the food which he consumes, because India is a huge country. There is a northern diet, there is a western diet, there is a eastern diet, and there is a South Indian diet. Each diet is different. So the very important thing is, first, according to the areas, the geographical areas in which you are residing, you should consult a dietitian. Pertaining to the restriction or the diet in diabetic nephropathy, how we can prevent the progression of diabetic nephropathy to the CKD is, first, protein restriction, but in the form vegetarian sources of protein should be continued. The non-vegetarian proteins, which are more rich in protein diets, should be restricted, because in majority of our patients, majority are vegetarian. So I don't think we need to restrict. According to the body weight, if it is a rough scale of 0.8 gram per kilogram per day is the protein which is being told to be healthy for the diabetic kidney disease patient. Mind it, for dialysis patient, suppose if your patient doesn't go for good shape and develops the end stage renal disease where he is on dialysis, say hemodialysis or peritoneal dialysis, whether protein restriction is there? No. Specifically when the patient is not on dialysis, okay, protein restriction to a tall of 0.8 gram per kilogram per day is accepted, not very low protein diet. But in a patient of hemodialysis oblique CAPD, that means peritoneal diabetic patient, that protein should be to a tall of 1.3 gram per kilogram per day. That means you have to give him high protein, otherwise because there is a loss of protein in dialysis oblique CAPD. So otherwise he will go in protein energy malnutrition. So that is a very important thing, that every CKD patient doesn't need, every diabetic nephropathy patient doesn't need a protein restriction.
Good. Thank you for highlighting on the protein and diet in the diabetic nephropathy. Sir, can you tell something regarding the treatment of diabetic nephropathy? If the patient has already developed the diabetic nephropathy, how we can treat, or if we cannot treat, then how we can halt the progression of the diabetic nephropathy in type 2 diabetes patients?
Very good. Once you have a thought, that means there are two sequences for this. Once a patient is a recent onset diabetic, he doesn't have complications. So the first and the foremost role will be prevention. Suppose if anyhow, because in India is a huge country, there are huge amount of non-followers, the patient comes once in a year to a doctor, doesn't get investigations, or rather thrice in a year, or every 4 years he comes and, okay doctor, now get my test done because I'm feeling this, that. So this is the biggest problem what we face being on an Indian medical part. The very important thing is, if he develops somehow this bad complication in the form of diabetic nephropathy or end stage renal disease, there are cutoffs. Initial part, a good glycemic control, a proper diet regimen, a proper blood pressure control is the key to go for diabetic nephropathy control oblique prevention. How? Diet, which I told you about, the protein restriction. The antihypertensive, we have good amount of data of ARBs oblique ACE inhibitors in the prevention of microalbuminuria. That is another very important. So hypertension control, diet control, followed by the glycemic control. The very important thing is the glycemic control. So these things has to be focused on diabetic nephropathy part. And second thing about the prevention of the complications of ESRD at a cutoff of particular damage, when you see that this patient may need further workup, I better refer a patient to a nephrologist so that he may have proper timely AV fistulas through, so that he may be in proper care for dialysis and everything. But very important thing is pertaining to diabetes target. Individualization of a target is a must in diabetic patients. In a CKD patient, you are targeting a tight glycemic control, may land in hypoglycemia. So good glycemic control is definitely good, but a good glycemic control in a bad patient is never good. So kindly don't ask any patient of CKD for a very tight glycemic control, because individualization stands for what? Individualization is in a CKD patient, in a CAD patient, in a CVA patient, in an old frail patient, you don't go for tight glycemic control targets, you just relax your targets on every part.
Thank you, sir. Thank you for widening our knowledge regarding diabetic nephropathy. Thank you very much.
Thank you. Dr. Sanjay Sharan is with me, and there's a very important confusion, because medical science now today in today's world is basically big of confusions. The various guidelines comes from this end of the country to that end of country in the world. There is a big confusion. So in diabetes, the biggest confusion is pertaining to the glycemic targets, pertaining to the diagnosis of diabetes, and there are two varied, say, different guidelines say that this much sugars are okay, this much HbA1c or glycated hemoglobin is okay. A different guideline says that this much is the A1C, which is the cutoff. So I want to ask Dr. Sanjay pertaining to that whether this difference in guidelines has an importance to the patient oblique to the medical fraternity.
First of all, treatment of diabetes mellitus should be individualized. Should be individualized on the basis of the life expectancy of the patient, age of the patient, cost of the treatment, also the polypharmacy, adverse effect. These on basis of these things should be individualized. Most of the guidelines, most of the recommendations, most of the society organizations, they recommend treatment of diabetes mellitus should be individualized. So as far as other recommendations are concerned, that ADA recommended that HbA1c target should be less than 7 in non-pregnant adults. As ACE recommend it should be in between 6.5 to less than 7 in non-pregnant adults. But recently ACP has recommended, American College of Physicians has recommended that it should be in between 7 to 8 in non-pregnant adult. So there's a lot of controversies there regarding that guidelines. So ACP has recommended, it's on the basis of the few landmark trials like ACCORD trial. In the ACCORD trial, they have seen lot of cases of hypoglycemia and also cardiovascular mortality and also all-cause mortality that was higher in case of intensive control of the blood sugar as compared to standard control, where in the intensive control where they put the HbA1c less than 7. In case of standard control, they have kept the HbA1c in between 7 to 8. So if we see compare the intensive arm and standard arm, so because of this all-cause mortality high all-cause high cardiovascular death and high risk of hypoglycemia and more severe hypoglycemia in case of intensive arm, and there were no significant increase in the microvascular or macrovascular complication in case of a standard arm. So according to ACP, they are saying in this ACCORD trial, if with the keeping the target little bit relaxed in between 7 to 8, we will not face many risk of hypoglycemia, we will not face the high risk of mortality, we will not face the more cardiovascular mortality. So it is better to keep it in between 6, 7 to 8. As far as other trials are concerned, like VDT trials, so here also in trials they have seen a lot of cases of hypoglycemia, and there was no major difference in between micro and macrovascular complications, though they have shown some benefit in terms of microalbuminuria, but clinical evident nephropathy benefit was not seen. As far as other benefits are seen, no retinopathy benefits are seen in case of VDT trials. Again here the mortality was not different in comparison to the standard arm or intensive arm, but if we don't see any kind of benefit, then why should we put the patient on the risk of hypoglycemia? So again the third trial, that was the advanced trial. In advanced trial also they have seen the high mortality, but it was not so significant, but again the risk of hypoglycemia was more. Even the neuropathy, particularly autonomic neuropathy, was more in intensive arm, but benefits was seen in terms of only microalbuminuria, that was seen more in case of the standard arm as compared to intensive arm. So on the basis of these 3 trials, mainly they make the guidelines to keep the patient on the HbA1c in between 7 to 8.
But what will be your take-home message for that? That how the patient should interpret it, that whether the HbA1c is, which is the HbA1c which is normal for the patient or for the diagnosis of diabetes?
Yeah, as I already say, treatment should be individualized. If the patient is young, well educated, then we should keep the HbA1c as low as possible. And if the patient is older age or very small kids, in those cases where the morbidity is also there, and other conditions like life expectancy is less than 10 years is there, and also patient is having other disease like cardiac disease or like that, at that time we can keep the HbA1c little bit relaxed in between 7 to 8, or in some cases it can be kept more than 8.
So individualization is the key. Thank you very much, Sanjay.
Individualization is the key of the
Thank you very much for this basic introduction. Thank you.
Myself Dr. Prem Narayanan. I'm an endocrinologist working as assistant professor in Department of Endocrinology, Amrita Institute of Medical Sciences, Cochin. Today the topic which I would like to discuss is about the pragmatic selection of cooking oils in diabetes. We all know that the diabetes is a very important epidemic that is happening in our country, and the numbers are rising like anything, and the role of diet in diabetes is very, very important. Especially so with the diabetes, we know that there are some micro and macrovascular complications. So basically it's a disease that affects the blood vessels. So the role of cooking oils, because oils are the major fat, and fat is one of the major macronutrients that we consume in our daily diet. And the oils are the most important source of the fat that we take in our daily diet. And so the oils, you can put it like oils mainly it contains the fat that contained in oils is the triacyl glycerols. That is, there is a backbone of the glycerol on which 3 fatty acids are fit into it. And fats can be, I mean the oils, the fatty acids are fit into it, and the fatty acids can be divided into saturated and unsaturated fatty acids. So you will know about that. So saturated fatty acids are the fatty acids where the carbon to carbon only single bonds are present in the molecule, and unsaturated fatty acids are fatty acids where there are carbon to carbon double bonds are present. When there is only a single double bond, it is called monounsaturated fatty acid, and when there is one or more, there is more than one, it is called polyunsaturated fatty acids. So these are the classification of the fatty acids, and apart from this there is another fat which is called the trans fats. These trans fats are very important because they are very notorious for the risk of the cardiovascular diseases. From where do we get the trans fats? Mainly the trans fats we get is from the partially hydrogenated vegetable oils that we consume in our daily life. And the importance of trans fat is that it is metabolized in the liver, it is not regulated by insulin, and it does not induce glycogen formation. In the daily life we get the trans fat, the contributions are mainly from the cake, pastries, cookies that we consume, the cornets or the chips that we consume, then fried potato chips, and also the popcorn. These are all the major source of trans fats that we consume. And these trans fats, because of their position of the side chain molecules, it almost behaves like a saturated fat. That is, it will be linear in the structure. So that is why it is most important, and it can lead to, it is not at all a heart healthy molecule. And we also get trans fats from the animal fats also, from the animals, ruminants like the cow, sheep, goat, and all. They are from there we get the animal trans fats. And there was a survey which was conducted in 2007-8 in India, which showed that the Punjab, Chandigarh, Haryana, and Delhi had the highest consumers of trans fats, and most of them the highest consumers, and most of them came from the partially hydrogenated vegetable oils. From my state, Kerala was lower down, but from my state, it was the second largest consumer of trans fats from the animals after the Jammu and Kashmir. So these are the trans fat data. So it's very important that trans fats are not at all healthy for our body. And next we move on. So there's as we have said, various oils. With these oils and the fats, we know there is a link between the cardiovascular disease. There is the increased risk of coronary heart disease. There was a hypothesis, that a diet heart hypothesis, which was the concept was put forward by Dr. Ansel Keys in 1956, where he published a study called 7 country study, which showed that established the link between the dietary fat and the risk of the coronary heart disease. So that was the platform when the saturated fats as a notorious agent came into the picture. And we all know that this diet heart, after the diet hypothesis, this the usage of the saturated fats came down, and there are other studies where there are 4 main studies where the core trials where the replacement of saturated fats with a polyunsaturated fat showed that there is a decrease in the coronary heart disease risk. So that was the platform where the oils about the concept of the unsaturated fatty acid oils were brought into the picture. And we all know that we all consume different types of oils daily, because pan India, if you see, there are different types of oils which are being used across the country. From my state, you all know that the coconut oil is one of the major oil that is consumed by the state, and as said, the saturated fat and the coronary artery disease risk, and the estimates of CVD prevalence in Kerala and was almost comparable to that of the global and also the high income country group. And previously saturated fats like the coconut oil was considered to be one of the major factor for that increased risk of CHD in Kerala. But recently there were studies which could not prove the causation risk, but definitely I would say that the coconut oil will definitely increase the LDL cholesterol level. The recently published Circulation Journal last month article showed that coconut oil consumption increased the LDL cholesterol by 10 milligram per deciliter and also the HDL by 4 milligram per deciliter, and it also increased the risk of the coronary heart disease. So that was about the coconut oil. And then other oils which are being used are also the commonly in our country that we use is palm oil is very commonly used. This is a saturated oil, and the palm oil is it has long chain fatty acid. Unlike the coconut oil which has medium chain fatty acids, palm oil contains long chain fatty acids which are considered to be more harmful to our body comparing it with the coconut oil. Then other oil which is used is a vanaspati. It is basically a hydrogenated fat, and you know the vanaspati contains around 53% of the trans fat content is present. So as we have already said that trans fats are notorious, so vanaspati can have a high amount of trans fats, and hence the usage of vanaspati should be brought down definitely. And the other oils that are being consumed are the mustard oil and the canola oil. Mustard oil and canola oil, they contain more of a monounsaturated fatty acids, and then other oils consumed are the olive oil, again monounsaturated fatty oils. Then groundnut oil also contains a good amount of monounsaturated fatty acids of around 50%. Then sesame seed oil, in Hindi what we call the tilka tel, the sesame seed oil is also there, which contains almost a proportionate amount of the saturated and the polyunsaturated fatty acids. So these are major description about the fatty acid components in the oil. And the next important thing in the oils is that oils are prone for oxidation. So lipids, we know that lipids are prone for oxidation, so like that oils are prone for oxidation. The major type of oxidation that occurs is auto-oxidation. Auto-oxidation means you don't do anything, you keep the oil just into the openly in the air, it will start auto-oxidation. It is mainly via the free radical mechanism, and it depends, the auto-oxidation depends on the degree of unsaturation, temperature, and the oxidative stability of the oils. And then other oxidation is the photo-oxidation, that is if you keep the oils in light, like in the transparent plastic bottles and all, that increases the risk of oxidation. Then the third is a lipo-oxygenase catalyzed oxidation, that is the rice bran and soybean oil. These two oils, these seeds contain high amount of lipo-oxygenase, so these are prone for lipo-oxygenase mediated oxidation even during the stage of processing itself. You know that? Do you know that processing of oils is a tedious process where it goes through many pathways, and first mainly the screw press. After the screw press is what we get the virgin oil. You would have heard about virgin oil, also known as a raw oil or the cold pressed oils. All these virgin oils, the thing is that they are not refined, because usually what happens is that what we get in supermarkets is refined oils. Refined oils means these virgin oils, they will be further refined, bleached, deodorized, and hydrogenated before it reaches the supermarket. So the virgin oils are unrefined. The advantage is that by refinement we lose the antioxidants in these oils, and that leads to less oxidative stability of the oils. Virgin oils are good in that aspect that they do not lose the antioxidants, and hence their stability is more compared to the refined oils. And but the smoke point of refined or virgin oils are low. So the virgin oils, they should not be subjected to very high temperatures. They should be used for processes like salad dressings or low temperature cooking or for flavoring. So this is about the virgin oils. And next we move on to from the refinement process. You all know because all these are important, because the oxidation can lead to harmful effects, because the oil loses its nutritive value, oil loses its shelf life. The oil, the oxidized oil, they are prone for mutagenic, then cytotoxic and carcinogenic risk will be there, and it can also damage the various membrane proteins and enzymes also. And next we move on to another process. Oils, we all know that rather than keep taking it raw, we mainly use it for frying purposes. Frying is a process where the oil is subjected to very high temperature of 150 to 190 degrees Celsius and in the presence of air and moisture. So this frying leads to when the oil is used for frying, three processes it undergoes: hydrolysis, polymerization and oxidation. This results in a various array of products like the acrolein, polar compounds and all other epoxides, aldehydes, ketones and all these products. So these can lead to if we are consuming the reused oils. When the oil is being reused many times, what happens is that if you consume this type of oil, all these secondary products of will enter our body, and that can lead to oxidative endothelial stress, leading to increased risk of atherosclerosis and hypertension. So that is the most important. Reused oils should not be used, because you know that after a single fry itself, you will be seeing black particles sedimenting under the oils. So these are the secondary products that happens after frying. In hotels or many shops, we know that they keep on reusing the oils, so that will lead to increased risk for many other diseases. So reusing of oils should not be done. And next, from the process of frying, so there are many studies which showed that the oxidative stability of oils at various temperatures and also at high temperatures for prolonged exposure. It showed that the virgin olive oil, extra virgin and just the normal refined olive oil and the avocado oil, these oils, the trans fat formation was dependent on temperature and not the exposure to heat. While the refined oils that we use, that is sunflower oil, there is a mustard oil, groundnut oil, all these refined oils that we use, the trans fat formation is dependent on the heat exposure rather than the temperature. So there is a varying effects that we get it from different oils after using it for frying. And there are various other studies. That is the most importantly, we know about olive oil. Olive oil is one oil with the most important content of that is the monounsaturated fatty acids, and olive oils can there are studies which show that it can increase the blood lipid profile and also the glycemic parameters also. And recently also from my institute, one unpublished data which showed that olive oil compared to the sunflower and also the coconut oil, olive oil improved the parameters of glycemia, and also olive oil improved the anti-inflammatory markers rather than the pro-inflammatory markers. So that was a benefit that which was obtained from the olive oil. So before concluding, so there are a lot of controversies about the usage of oils and the saturated fats. So are saturated fats really harmful? Saturated fats are definitely, it should be used in moderation amount only, as usually 7 to 10% of calorie daily intake can be constituted by saturated fats. And coconut oil, if you ask, is coconut oil healthy? Yes, definitely it is good, only because there are various benefits also, and there are certain disadvantages also. So the increased risk of LDL, but it has not so far been proven that this increase in LDL is resulting in increased risk of coronary heart disease. And apart from that, then other problems will be the reusing of oils and adulteration, which should be definitely monitored into. And before concluding, the conclusion remarks mine would be: least oil is the best, and never reuse any oil, it is always harmful, and trans fats are definitely not heart healthy, and use oils, saturated fats in moderate amount only. Thank you.
endocrinologist based in Kolkata. So today I have come to for a program in SPEEDCON in Delhi, SPEEDCon 2020, and where I was involved in a debate regarding recent, not too recent, 2018 guidelines of the ACP, that means the American College of Physicians, which tells us that in most patients with diabetes, the target HbA1c or the glycosylated hemoglobin A1c should be less, should be 7 to 8%. That's what they have said, and I actually spoke against the motion. So throughout, for many decades now, 2 decades let's say, we have had evidence that a HbA1c or a glycosylated hemoglobin of less than 7% is what is ideal for most patients with diabetes. Why did we come to this HbA1c of less than 7% as our target? Is based on very important studies like the UKPDS study, which took place many years back, and it was a long-term study where it was found that in patients with type 2 diabetes, when you treat patients to an HbA1c of less than 7%, then there was a decrease in the microvascular complications of diabetes. And there was a trend towards a decrease in the macrovascular complications of diabetes. Now, these UKPDS people, the population, were again followed up for many more years, and which is known as the UKPDS follow-up study. And here it was found that in patients who are assigned to good glycemic control, that is to an HbA1c of less than 7%, even 10 years after the study ended, the benefits were still seen, and at this time there was a decrease not only in the microvascular complications but also the macrovascular complications, like let's say atherosclerotic cardiovascular disease, all-cause mortality. So this tells us that in patients with type 2 diabetes, especially in the early years, if we give them good glycemic control of an HbA1c less than 7%, then it is a good investment for the health of the individual, in the sense that it would decrease immediately over the short term, decrease the microvascular complications like retinopathy, nephropathy, neuropathy, but over the long term would also continue to decrease the microvascular complications, but would also decrease the macrovascular complications. So similar study was also conducted in the diabetes, which was known as the DCCT study, and the follow-up is known as the DCCT EDIC study, which also gave the same result, that is, yes, in the early years it would decrease the microvascular complications, but over the long term also you have some macrovascular benefit. So when the ACP came with the guidelines that it should be 7 to 8%, the target, it was out of it like a ball from the blue. Why did it happen? So ACP also considered some other trials known as the ADVANCE trial, the VADT and ACCORD trial, where in these trials, so to tell specifically this ADVANCE, ACCORD or VADT, in these trials the study group or the population which was studied were much older than in the UKPDS. They also had longer duration of diabetes and they had established cardiovascular disease. Now in these trials it was seen that there was a decrease in the microvascular complications, but for the macrovascular complications they were short term, it was a short study and the macrovascular benefits were not seen. Also in one study known as the ACCORD, because of the design of the study or because of how the HbA1c was brought down, rather than the target HbA1c, there was increased mortality or death. So as a result of it, the ACP came down with this target of 7 to 8%, but that is not the way to look to. What we need to understand is that since throughout this so many years we have understood that good glycemic control improves cardiovascular outcomes, good glycemic control prevents microvascular complications, and over the long term also improves cardiovascular outcomes, we need to consider this and we need to individualize our targets. So let's say if it's somebody, a young person, or even if the person is not young, the person has a very long life expectancy. in that case we would target an HbA1c of definitely less than 7%, so that the person would reap the benefits of a good glycemic control regarding the prevention of micro and over the long-term macrovascular complications also. But obviously, if the person is an older person, has many comorbid conditions and has a shorter life expectancy, in that case we would not make such a huge target, such a target of, let's say, less than 7%. We would relax our targets, maybe 8, sometimes even 8.5%. And we should also remember that by the time the UK-PDS was published, or for that matter, when the Accord, the VADT and the Advance were published, we did not have so many anti-diabetic drugs like we have today. What the UK found out was that the lower the blood glucose or the HbA1c, the lower it is, the better it is to prevent complications. But the problem with the lowering the blood glucose at that time was the fear of hypoglycemia, because at that time anti-diabetic drugs were known as oral and hypoglycemic agents. In fact, nowadays we don't use the term hypoglycemic agents, we use the term anti-diabetic agents or anti-hyperglycemic agents, because of the fact that the newer drugs, whether it is the gliflozins, whether it is the gliptins and the GLP-1 receptor agonists, they do not cause hypoglycemia. In fact, they just decrease the blood glucose that is raised, but they by themselves do not cause hypoglycemia, and also they are weight neutral or cause weight loss. So we have a large number of drugs which can give good glycemic benefit, at the same time do not cause the feared complications of anti-diabetic agents, that is hypoglycemia and weight gain. And therefore, in today's time, when we have a lot of agents, when we have evidence that HbA1c less than 7% is beneficial for somebody who has a long life expectancy, in those individuals, definitely we should target an HbA1c of less than 7%. In fact, we can get the HbA1c less than 6.5% without causing undue problem to the patient in the form of hypoglycemia or others, then we can in fact even lower it in, let's say, somebody in his 30s or early 40s. So in India, people are developing diabetes at a very young age, and therefore we see that the exposure, the overall exposure to diabetes is decades, and we need to protect the organs and the vasculature of this individual from the complications. And if we look from the cost perspective, it may seem that somebody who is being given a number of drugs so as to prevent the rise in HbA1c or the diabetes complication, it seems that it is an expensive affair. But if we look at the overall context of expenses, and if we extrapolate the data or the expenditure, we see that it is not only cost effective, but it is also cost saving. Because if the person, so it is like a small insurance we pay, let's say, for our good health, we can take it in that way, because for somebody who has a good glycemic control, not only glycemic control, but who has also control of blood pressure, lipids, stop smoking and all these things, in all these individuals, the chances of a diabetes complications are much reduced. And therefore, investing in the cost for some good diabetes care, whether in the form of lifestyle, whether in the form of pharmacotherapy, will actually decrease the diabetes expenditure, diabetes related expenditure in the future. And therefore, it is a long-term investment, which I would say is more than cost effective. Cost effective means you get the same return for the amount of money that you have invested. It is cost saving, that means you get more returns, because it is health saving, and in that matter it is life saving. And therefore, in the times we live in today, where diabetes is diagnosed at a much younger age, where we have a lot of anti-hyperglycemic agents that do not cause hypoglycemia or weight gain, and because of the evidences we have had from the UK-PDS and the recent trials, what we need to understand is that in most of the patients with diabetes, we would target an HbA1c of less than 7%. But then again, each and every guideline says that we have to individualize our patient, and therefore it depends on who our patient is. So if our patient is an elderly gentleman who has severe comorbidities in the form of, let's say, a chronic kidney disease, chronic liver disease or atherosclerotic cardiovascular disease, in those individuals our targets will be higher, and we will in fact in somebody with an end of life care, our target would be just to prevent asymptomatic hyperglycemia. Whereas in younger individuals, it's not rare for us to find teenagers who are having type 2 diabetes today. In those patients, because the exposure to hyperglycemia and other comorbidities that are associated with diabetes is so high, in these individuals we will have an individualized target. And I would like to end by saying that diabetes treatment is not only about glycemic target, it is a holistic approach where we take into account the patient's lifestyle, the patient's, yes, and for that matter the family, the society has to support, the patient's control of not only glucose but also other cardiovascular risks, whether it is a form of hypertension, whether it is a form of dyslipidemia, whether it is in the form of smoking. All this should be controlled, and a holistic approach is the most important thing for diabetes care. And here the most so it is a multidisciplinary and a holistic approach where the center point or the center of the care is always the patients. Thank you.
Good morning. I am Dr. Kumaravel, endocrinologist from Madurai. I am available here in SPEEDCON to discuss the adjuvant therapies in type 1 diabetes. I think it is something which is very important for us, because we all know type 1 diabetes is a chronic metabolic disease which leads to, or which is probably related to, absolute lack of insulin, and insulin has been the cornerstone of therapy for type 1 diabetes. But unfortunately, in spite of various insulin preparations and advancement in administration techniques, we are not able to achieve the desired HbA1c control for those patients in our type 1 diabetes. The reason could be multifold, but one aspect we are trying to look at it is whether any add-on therapy to insulin could help us in achieving the glycemic control. So when I say add-on therapy, we can try to have a drug which reduces the immune-mediated destruction of your pancreas. We can have a drug which could help in replacing your pancreatic cells. But what I would focus is the drugs which could be added to insulin in treatment of type 1 diabetes mellitus. The first drug I would discuss is the metformin, and other drugs which should be available would be alpha glucosidase inhibitors, acarbose, miglitol, oglibose. We have DP4 inhibitors, we have GLP-1 analogs, we have SGLT2 inhibitors, but the only drug which has been approved for adjuvant therapy in type 1 diabetes along with insulin is pramlintide, which is available as Simulin, and it works in a way like it suppresses your glucagon, thereby it reduces your postprandial glucose, and it also causes hypoglycemia, it causes weight loss. So that is the only approved indication. But again, pramlintide is approved only for those patients with type 1 diabetes more than 18 years of age. Children with type 1 diabetes, it may not be useful. The challenge with pramlintide is, one, it is again injectable, and patient has to take at least 4 injections per day, which is the dose ranges somewhere between 15 to 19 microgram per day. So for those patients on type 1 diabetes who are already on basal bolus therapy, they are already on 4 insulins per day, and these patients again adding another 3 or 4 injections of Simulin is going to be a big challenge. And whenever you add these drugs for those patients, both injections should be given at least 2 inches apart for these patients. Another major limiting side effect or adverse event of this pramlintide is your nausea. Your nausea vomiting is very severe for these patients, and that is one of the limiting factors in using this pramlintide. So though this pramlintide is FDA approved drug, it has been approved by FDA even in 2005, approved drug for the use of add-on or adjuvant therapy in those patients with type 1 diabetes. Because of its various adverse events, it has not really taken off and people have not used much. Another drug, though it could be off-label, which has been used much, is a metformin. And metformin added to insulin, your insulin dose, we are able to see there is 20% reduction in the insulin dose, there is no weight gain, and adding metformin, there is no hypoglycemia also. So metformin should be suitable for those patients with type 1 who are obese, whose insulin requirement is at least 1 unit per kilogram per day, and in spite of varying doses of insulin, they are not able to achieve the HbA1c control of less than 8. But whenever you add metformin, remember, you should be able to reduce the dose of insulin, at least the basal insulin we would be able to reduce. The other drugs which I would like to discuss is your incretin based therapies, which is GLP-1 analogs. We have data on exenatide, we have data on liraglutide, but of course these drugs help to reduce your prandial insulin, but they don't try to reduce your basal insulin. In contrary, metformin helps to reduce a basal insulin, it does not help to reduce a prandial insulin. So GLP-1 analogs, again it's a insulin. The reason why GLP analogs were considered is that because the preclinical studies have shown the beta cell preserving effect of these drugs. So people try to look whether these drugs could help to preserve your beta cell, and it reduces your glucagon, and it reduces the postprandial glucose, and we know postprandial glucose is a independent, or postprandial hyperglycemia is a independent risk factor for a cardiovascular disease. So GLP-1 analog, it can help in reducing HbA1c, but it can also help to reduce other it can have your cardiovascular benefits. DP4 inhibitors, of course you have various studies in DP4 inhibitors, but to date there is no hardcore evidence to suggest DP4 inhibitors could be used as a adjunctive therapy. The next adjunctive therapy is alpha glucosidase inhibitors and miglytol, and these drugs help to reduce your postprandial glucose, but remember all these drugs has been used on top of insulin, and these drugs are never a replacement for insulin. And the final drug which I would like to discuss is SGLT2 inhibitors, and recently SGLT2 inhibitors has been the major focus in diabetes mellitus, because the mechanism of action of SGLT2 inhibitor is totally shifted from pancreas to your kidneys. Till now we have been looking at pancreas as a treatment for diabetes mellitus. We looked at therapies which increase your insulin, which looked at therapies which could be glucose dependent and glucose independent action. First time we are looking at a drug which has a pancreatic independent action. So SGLT2 inhibitor basically inhibits your glucose reabsorption from the renal tubules. So it increases your glucose excretion, thereby it reduces the blood sugar. So in type 1 diabetes, you have a insulin which has a different mechanism of action. You have a SGLT2 inhibitor which again has a different mechanism of action. So adding these two drugs can help to get a good glycemic control, and adding these SGLT2 inhibitor in these patients would help to reduce the insulin dose, and it can cause weight loss in those patients. So it could be considered in those patients who are obese, type 1 diabetic, where they are requiring high doses of insulin. But the concern with SGLT2 inhibitors, one, because of the renal glycosuria, there could be an increased renal genitourinary infection which has to be kept in mind, and because of a glycosuria you can have polyuria in some patients, it can predispose to dehydration, and more importantly diabetic ketoacidosis is one of the life threatening complication in those patients with type 1 diabetes. And patients on SGLT2 inhibitor, you have DKA which is precipitated even in lower glucose levels. For example, even with blood glucose levels of 200 you can have a patients with DKA. So any patient with symptoms of diabetic ketoacidosis should be monitored irrespective of a blood glucose. So these are the various drugs which has been tried, but as of today, apart from pramlintide, none of the drugs is FDA approved, though ADA gives certain guidance in adding metformin, and we find metformin alpha glucosidase inhibitor to be a more useful drug, not much of side effect while using in type 1 diabetics patient on top of insulin. SGLT inhibitor seems to be very promising, but I think we need more data to use these drugs in those patients with type 1 diabetes along with insulin. Thank you so much.
diabetes, we all know, is a major risk factor for development of cardiovascular disease. Some people may not consider it as a cardiovascular risk equivalent, but their cardiovascular diseases increases up to 2 to 4 times in patients who are having diabetes. So we need to have some strategies in by which way we can prevent these cardiovascular diseases in patients with diabetes. And there are multiple trials which have been done on various aspects, various pathways, targeting the various pathways which leads to the cardiovascular disease, including the lifestyle interventions, using statins for controlling dyslipidemia, using antihypertensives. So all these factors are already in use, and one of the pathway which we want to target is the platelet activation in diabetes patients. So in diabetes patients, especially, the platelets get hyperreactive. So we need some targeted therapy which can actually act upon this and which might prevent the development of cardiovascular disease, and that's why there is a role of aspirin in the prevention of cardiovascular diseases. Well, there is no doubt that aspirin is recommended and it is beneficial in those patients with diabetes who already have a cardiovascular event, like who are already have suffered an MI or a stroke or any peripheral vascular disease. In those patients, aspirin has a proven benefit. This is called secondary prevention. There is no doubt about it. However, the controversy is the primary prevention. So the controversy is whether using aspirin before development of any vascular event, can it prevent or can it prevent the development of these cardiovascular events. So the role of aspirin in primary prevention, the trials on this with the use of aspirin as a primary prevention started in late 1980s. So initially those trials were focused mainly on the general population. The diabetes population was not included, and those results did not show any significant benefit, which led to FDA to say that aspirin is not recommended for primary prevention in 1970s as well as late 1980s as well. However, in late 2000s, the studies on diabetes population started appearing. The two big studies were one was done in the Japanese population, and there was another study, an ETRDS study also. So these studies in late 2000s were done mainly in the diabetes population for the prevention, for use of aspirin as a primary prevention. And what these studies revealed, that there was non-significant reduction in the cardiovascular events, and hence again FDA stood by its point of view that aspirin is not recommended as a primary prevention. However, the downside of these trials were that these studies were underpowered, and because the cardiovascular events which were anticipated were quite high, but then actually what happened were quite low. These studies were underpowered, and 10 years later now came this study called Ascend study, which was published in 2018 in NEJM, which was actually done in a very targeting mainly the diabetes population. It has been till now it has been the largest study for the use of to show the use of aspirin as a primary prevention in the diabetes population. It included around 15,000 patients, and it randomized these 15,000 patients with diabetes were randomized to receive equally to receive either aspirin 100 milligram daily or placebo, and then these patients were followed up for a mean period of around 7.4 years. And the primary outcome was basically the composite of the serious vascular event, which was a composite of MI, stroke, TIA, or any vascular death. So what was found after following up these patients and after 7.4 years, that patients who were taking aspirin, the events occurred in 8%, whereas patients who were taking placebo, the events were on the higher side, 9%. So that means there was the relative risk was 8.88. That means it led to 12% reduction of use of aspirin in diabetes population, led to 12% reduction in the development of first serious vascular event. Now this was a composite outcome. However, when the individual outcomes were looked into, there was no significant difference. However, still this led to modest beneficial effect. Now if you look at the benefits, then there were another biggest trials which were done with the use of aspirin as a primary prevention the same year, the ASPRI and the ARRIVE trial. The ASPRI trial, which was done mainly in the elderly, also included around 11% of diabetes population, whereas the ARRIVE trial was excluded diabetes population, and these two trials actually did not show any benefit with the use of aspirin in the primary prevention. So, updated meta-analysis which was done in 2019, which included the ASCEND and the ASPRE trial, also showed that if you look at the overall vascular mortality, there was no significant benefit with the use of aspirin as a primary prevention. But if you look at the MACE as the main outcome, then aspirin did show some improvement, some reduction, which is in the tune of 9%. So, modest but significant reduction in the MACE outcome in this meta-analysis. Now, this has been the benefit of use of aspirin in primary prevention till now. What are the risks? The risk is mainly the bleeding risk, and what was seen in the ASCEND trial that this major bleeding risk increased by 29%, and the main bleeding site was the GI tract and upper GI tract. However, there was no significant difference in the terms of the fatal bleeds or intracranial hemorrhage if you compare the aspirin and the placebo group. So, and also subsequently the meta-analysis which was done including this ASCEND trial for the look at the safety outcome, it was shown that in the diabetes population there is significant increase in the major bleed with the use of aspirin, predominantly the GI bleed, but there is no significant increase in the intracranial hemorrhage, which is in contrast to the meta-analysis which included both diabetes as well as non-diabetes population, which showed that there was the risk of bleeding was even there of intracranial hemorrhage as well. So, looking at this benefit and as well as risk, how do we reconcile the results? How do we balance it out? So, actually it's very difficult. It's the biggest challenge, whether we can weigh both the events, a bleeding event and an ischemic event equally or not. We don't know what will be the long-term consequences of these two events. So, the number needed to treat in ASCEND trial was 91, whereas the number needed to harm was 112. There is a fine balance between the benefit and the risk. The benefit was not much, but the bleeding risk was much higher. This is as opposed to in secondary prevention trials with aspirin, which has clearly shown that benefit extends much beyond the bleeding risk, and therefore the ratio is much superior for the benefits. Now, what could be the reason that we are not getting the good benefit with the use of aspirin in the primary prevention? One of the reason is that now since the availability of statins and the improvement in the lifestyle factors, that already the risk factors which cause the cardiovascular disease are well controlled. So, even in the ASCEND trial, the population was low to moderate risk. It was not a high risk population. So, maybe all the factors have already taken care of with the use of statins, smoking cessation, blood pressure control, other lifestyle measure. If you add aspirin on top of that, it will not lead to much benefit. Other speculation is that in many of these trials, the adherence rate was very much less with aspirin. So, we don't know whether it clearly led to the benefit or not. There is a possibility of aspirin resistance in diabetes patients, that aspirin may be not acting properly with such dosages. However, in ASCEND trial, it was clearly shown that there was no significant difference in terms of the it has been also been speculated that in obese patients, aspirin dose might be required as higher. However, in the ASCEND trial, it was shown that outcome was same even in the obese or the normal weight patients. Now, the other possibility is that in these trials are not selecting very high risk population on the basis of the modern CAC score, and also we cannot say how much patients were using NSAIDs and alcohol, which had increased the bleeding. There are many confounders and could be there which can say that bleeding risk is high and moderate efficacy is less. So, what are the recommendations? As per now, the two major recommendations which we follow for patient diabetes, the European guidelines and the ADA guidelines. So, what European guidelines say is that you can use aspirin for primary prevention only in the high risk or a very high risk population. So, how it define high risk population is that those patients who have either target organ damage in the form of a kidney proteinuria or a kidney damage or an LV dysfunction or a retinopathy, or patients who are having 3 or more major risk factors in the form of obesity, hypertension, dyslipidemia, smoking, or a premature family history of premature cardiovascular disease. So, these patients are defined as having a very high risk or high risk population where aspirin can be used for the primary prevention. However, it does not advise to use aspirin in the low risk population such as age less than 50 years or who are not having any other risk factors. Similarly, ADA recommends to use aspirin in patients with more than 50 years of age who have one or more major risk factors in the form of again hypertension, dyslipidemia, obesity, smoking, or a family history of premature atherosclerotic cardiovascular disease. But the main common thing which both the recommendations say is that you need to rule out a high bleeding risk in a patient. These patients are, we need to screen such patients who are at a high bleeding risk, such as older age, who have anemia, who have thrombocytopenia, history of a GI bleed or a history of a GI ulcers. So these are the patients in whom the aspirin should not be prescribed. So it still remains a controversial issue, or more or less it is very clear that aspirin should not be used routinely in patient with diabetes. It's not like diabetes patient is coming to you and you're writing an aspirin. That is completely out. It's better emphasis should be given to the risk control of other risk factors in the form of optimal use of statins, optimal use of antihypertensives, lifestyle measures, smoking cessation, which can actually abate most of the cardiovascular risk in these patients. And so aspirin use might be restricted to certain high risk population, and identifying this high risk population could be a challenge. So one way is high risk you can call when these patients have one extreme risk factor in the form of, if it's heavy smoker, the patient has premature family history, premature atherosclerotic cardiovascular disease, or if the patient has uncontrolled lipids, blood pressure despite on the drugs. So these are the candidates who will benefit from the use of aspirin therapy. Or maybe the use of CAC score can identify these high risk patients. So if the CAC score is more than 100, these patients can benefit from aspirin therapy. Whenever aspirin therapy is to be used in primary prevention, it should be used in the lowest possible dose in the form of 75 to 100 milligram. Underlying bleeding risk should be ruled out, and also these patients, patient discussion is very important. What patient wants, what patient prefers, whether patient prefers a bleeding event over ischemic event or a ischemic over a bleeding event, that becomes very important. So as of now, aspirin in the primary prevention threshold has become very high now to start for aspirin for a primary prevention of cardiovascular disease and diabetes. Thank you.
I'm Dr. IPS Kocher, adolescent endocrinologist and diabetologist at Indraprastha Apollo Hospital, Delhi. Today I will be telling you more about diabetes, because we have been attending this SPEEDCON, we are learning more and more. So we should be more careful about our diabetes. First of all, it's increasing a lot, the incidence of diabetes increasing a lot in our country, especially in India. More and more people are getting diabetes. Why more and more people are getting diabetes is because the lifestyle has changed a lot. Now we are having people who are eating all the time, they're sitting, they're not doing any regular exercise, so they are more prone to diabetes. Genetically also many people are prone to diabetes. Family members who have diabetes, the chances that the mother, father, the child will get that. So all is very important is to understand that this diabetes is why there are different types of diabetes. Type 1 diabetes, type 2 diabetes. In type 1 there is diabetes which is only you have insulin, and type 2 diabetes you have both in an adolescent population and in adult population. The people who are having type 2 diabetes, basically what's happening in them is that their insulin is becoming less, as well as they are getting insulin resistance to insulin. So as a result of which their insulin does not able to act, and then ultimately they start having high sugars, and because of the high sugar they get certain symptoms. The symptoms may be like polyuria, polydipsia, polyphagia. They may get infections, recurrent infections. They may have weight loss also, but chances that there's less. They may, most of the time it's weight gain. So this problem of diabetes will cause them to get other complications, which if they don't get their sugars under control with drugs or other methods, they will finally land up with complications. The complications could be heart problems, it could be cardiovascular, it could be kidney problem, kidney failure, kidney damage, different stages of chronic kidney diseases. They may have problems with the eyes, they may get retinopathy, they may get blood vessel problems. So all these problems are known to occur with chronic diabetes if diet persists for a long time. So as you can see, diabetes is a chronic condition and it keeps on going on. You have to take control of your sugars. If you do not that, you will land with various complications. So that's why diabetes has to be well controlled. So there are a lot of drugs which are being used for diabetes, as well as insulin if you need it at all. But most important is the drug. Now the other important thing is that whenever we talk of diet, the very important thing is whenever whatever medicine you will be taking, lifestyle is very important. You must have a good regular exercise, at least 30 to 40 minutes of exercise. If you do it at least 5 to 6 times a day, or 5 to 6 times maybe in a week, if you do a moderate exercise, it is really going to make a difference for your sugars, for your dental built, and even your body will insulin will become better and acting on the cells, so that glucose metabolism will be better. Now besides this, you have to balance your diet. You must take at least 40 to 50% of carbohydrates, you must take 23% of fat, 10 to 20% of proteins. So overall with minerals, this will improve your diabetes control and will also keep a better control on the diet. So that as a result of which you will be able to have a better requirement, the sugar will be well controlled. Now another very important thing to understand is that once you do a good exercise, once you maintain your life, you should avoid eating a lot of junk foods like like pizzas, burgers and Maggies, especially in the adolescent type 2 diabetes. They should avoid all these fatty foods and all, because obesity is going on the rampant, and this obesity is causing all this type 2 diabetes in the adolescent population, and even in adults. You find a lot of obese patients now at a young age of 30, 35 landing up with diabetes, and very obese with high BMIs. So we have to give a good control, a good holistic approach. So it's not the drugs, it's basically drugs, your medications, your lifestyle, your exercise, your food habit, all will make a difference in the control of diabetes. That is why we have to make it a point that's saying. Now coming on to type 1 diabetes, this is normally seen in the young ages of like 1 year, 2 years, 5. This is also increasing. The incidence of type 1 diabetes is also increasing a lot now these days. More and more children are coming up with diabetes. The reason is we don't know exactly, but they say it's maybe an autoimmune phenomenon. But there also it is very important to have a balanced diet. So because there also a holistic approach should be there, that you're taking insulin along. The only thing you can use is insulin that. But along with insulin, you have to make sure that you're giving a good diet, the balanced diet, and the child is doing regular exercise. So all that makes a difference. So it's very, very important that we, when we are managing diabetes, we have to take all these consideration of exercise, balanced diet to maintain good sugars. Now, it's very important, another thing very important, to prevent these complications. If complications, you know, you have to complete your sugars under control. There are various ways people talk in terms of HbA1c, keeping it less than 7. There are other people that say that you keep between 7 to 7.5. There's new thing which is coming, is called as time in range. So keeping your sugars in between 70 and 160. So if you keep the sugar in time in range most of the time, that means your chances of that you will not get least complication. So that's what, you know, and what we have to be very careful about, that we do not land with complications. So whatever you are doing as far as diet is concerned, taking medication, you must do regular exercise also. So overall, yes, the diabetes is increasing. We have to make our way to fight against this diabetes, which is going on increasing in the, you know, in our country, especially in India. So that we have to make more and more people aware of it, and make more and more people aware of it, more and more people understand the diet pattern which will be followed, and along with the regular exercise, besides if already you have become a diabetic, taking medication. So that's why overall I think, you know, it has to be a very holistic approach, that medications with diet with long exercise, whether we're talking about type 1, or whether we're talking about type 2 diabetes, or we're talking type 2 diabetes adolescents, or we're talking type 2 diabetes adults. So all this has to be taken. Taking drugs, there are different combination of drugs available which everybody can find out from, you know, whoever is a doctor, endocrinologist treating you. But overall, besides this, it's very important. Awareness has to be made among this population, whoever you are seeing, or seeing the patient, or whatever you're doing. You make people understand about it more and more, so that it can be picked up earlier time and can be managed early, and then, you know, they can have a longer life of preventing complications work. Thank you very much.